So I am a licensed mental health counselor. I've been counseling for 19 years in a variety of different settings with a variety of different demographic people. I am the chair of the mental health subsection of the American Association of Pro-Life OBGYNs, otherwise known as APLOG. And I am a molestation and rape survivor and a post-abortive woman. And I add those things not because they really impacted my opinions about this case specifically, but just so people know I have that personal experience with it. And I will try to, as I did in the other podcast, if something's a personal opinion versus a fact from my professional work, I will let people know, like, that's what this is.
I appreciate that. That's great.
Yeah. And abortion is not a standard practice of care for trauma, for any type of trauma. It doesn't treat trauma. So in cases of rape, whether or not somebody's pregnant, abortion isn't how we treat the trauma of rape.
Yeah.
We treat rape through different types of therapeutic techniques, cognitive behavioral therapy, prolonged exposure therapy, EMDR. There's all kinds of different ways we can treat trauma around rape. And it absolutely needs to be treated, and these cases need to be referred, and it would be my preference that victims don't have to pay a dime for any of it. So we have a really terrible habit on both sides, pro-life and pro-choice, talking about pregnancy from rape as if it's inevitable the pregnancy is going to be traumatic. That's just inherently the outcome, which is actually statistically not the case. Statistically, 50 to 80%. Now, let me be specific. There's only 2 research papers written on this, and they're very small sample sizes, so I don't want anybody like extrapolating this to, if they know somebody personally, their response should be this. But the data we do have says 50 to 80% are going to choose to continue the pregnancy and look at it as an opportunity to not only reclaim their own independence, their own power, their own agency, their own body, but to protect the second victim and offer that victim security, sanctuary, and protection from violence. So overwhelmingly, it's not the case that pregnancy out of rape is inherently traumatic. So we need to separate the two. When you think about physiologically rape and what abortion is physiologically, abortion doesn't impact rape at all on a physical level. It doesn't do, like, the rape doesn't not happen because you have an abortion. And so same with the mental health. It's not like the rape is any less traumatic because you've had an abortion. Now, you are correct that abortion can end a pregnancy that is traumatic. And so that's where I would start to say, okay, this is a genuine conversation around if pregnancy is traumatic, should we offer abortion in that case? And so I just want to go back and stipulate rape and pregnancy are separate things. Yeah. Completely separate things. The way I would counsel or treat trauma from rape isn't going to change whether there's a pregnancy or not. The trauma from the rape is not going to change. How I treat that is not going to change.
Interesting. And for what it's worth, abortion practitioners, I think, know exactly what Robin's talking about because, I mean, it's just the amount of facts that are stuck in my head that I only have used in 15 years ago. But Dr. Warren Hearn is the abortion practitioner who wrote, like, at least for a very long time, the medical textbook on abortion. Every abortion practitioner wrote it. It was called Abortion Practice. And there is a quote in that book, and I'll link to a picture or a link or something, but he, in a small section about rape, he literally says abortion does not unrape a woman. Like, this is not some weird, like, pro-life view or something going on. Like, abortion practitioners know this too. It's just, I think a lot of people in the public don't understand it.
That's a super helpful clarification.
Yeah, I appreciate Hearn saying that because I often hear we need abortion when a woman's suicidal. We need abortion when she's pregnant from rape. We need abortion in all these ways that pregnancy can be traumatic. And so that's just a nice segue into, if we separate the two things and we know how we treat trauma from rape, how do we treat trauma in pregnancy? And so something you said, Josh, it must have been a year ago, really stuck to me. It was a private conversation. I hope you don't mind me sharing.
No, it's fine. Go ahead.
It was something along the lines of, if we're going to allow for violence against a human being, we better be darn sure that's the best option. And so when I think about all the different ways pregnancy can be traumatic. So one of my pregnancies was traumatic. It was high risk. I had hyperemesis. Was bedridden for almost the entire pregnancy. There were several nights I contemplated suicide. It was very difficult.
Terrible.
Wow.
Yes, and actually, hyperemesis has a 50% increased risk of suicide compared to other pregnancy complications because it is so physically miserable and isolating. But so that's just one example, and I share mine because I'm not going to share patient information.
Right.
I will talk in general that, yes, I've lots of patients that have lots of different types of pregnancy trauma. That does happen. It's not uncommon. I know I've seen a few very prominent pro-lifers talk about like pregnancy is not traumatic, birth is not traumatic. You know, in the vast majority of pregnancies and the millions we see, no. But because it's my specialty and I have a long wait list, I can tell you it happens with some regularity. So, yes.
And even if trauma doesn't happen a lot, pregnancies are still hard in general. I know,
we just recorded a podcast
just recorded
on
an
this.
episode. In fact, I think this is going to come out before part 2 comes out, which is really going to annoy some people who've been really wanting part 2 of
part
8
1
types of difficult pro-lifers. But Monica Snyder, was this in part 1 already?
This was in part 1.
This is already out. So
Monica Snyder talked about, we recorded the podcast while she was 8 months pregnant.
Yeah.
And she openly hates being pregnant. And we've talked extensively about how pro-life people need to stop trying to downplay how hard pregnancy is, and that even a normal pregnancy has very big side effects on your body and on your like mental health and on your physical health and on all the things in your life. Like a normal pregnancy is extremely difficult.
Yeah.
And so we need to stop downplaying this. And certainly there are pregnancies that are well beyond the scope of the normal. And those are the kinds of ones that you are often seeing, Robin. And so all pro-lifers need to acknowledge that all types of pregnancies happen, but even a normal one is going to have some really difficult experiences.
And Robin's not doing that, but I'm just saying, like, Robin's talking about trauma, which is like this different thing. I want to make sure everyone understands these kind of two different things.
Yes, and I want to add, just in general, if I could give a piece of advice to any pro-lifers.
Please do.
If you lean into truth, even if it seems at the moment inconvenient, like pregnancy is hard, when you lean into it, you find out just how ill-equipped abortion is to deal with these things. So imagine the millions of women who want their pregnancies. And rather than our society investing time and energy and skills and money into addressing how difficult pregnancy can be and becoming a pregnancy-inclusive society, we offer them abortion. You don't want to deal with it, just get an abortion. Abortion has been a Band-Aid for all of these injustices and in ways that women have been not treated equal, these inequalities regarding just their own biology. So abortion really is the dismantling of a woman's healthy biology. If pregnancy has happened, it means a woman's body has reacted to stimuli in a healthy way. Right. And so rather than how do we then support the complications with that, it's just, so if you lean into truth, often you'll find where we need to be addressing our attention rather than trying to pretend things aren't difficult. Suffering happens.
So I'm
when I think about treating pregnancy from trauma, to bring it back around to that, the ways we treat that in wanted pregnancies, it's the same way we would treat it in unwanted pregnancies. The same therapeutic techniques are going to work. We might have to employ additional ones. It might take longer. The choice on the other end might be different as far as whether or not that person raises that child. We don't have any stats on that. It's just not researched.
Sure.
So I think that we need to take in consideration, if we tell people abortion is treatment for pregnancy from rape, then we're telling people who don't have abortions after pregnancy from rape, they're not healed. Their treatment was somehow invalid. No. And abortion isn't a mental health treatment. Now, that being said, it is absolutely true that many women, whether or not they've been raped, feel relief after an abortion. And I in my own, and I think I talked about this on one of the podcasts we recorded, I had some relief around I'm not tied to the father of that. And that's still true. I am grateful he's not in my life. I would take the abortion back in a second and have him in my life today if I could have my son back. But it is also true that I'm relieved. So we can't pigeonhole that either. We can't say relief is the only emotion and therefore abortion is treatment of trauma. No. Statistically, in research around mental health and abortion, relief doesn't stick around. It comes and goes, just like grief, guilt, shame, all of those things come and go.
Yeah.
And so one of the things that, just to kind of wrap all of this up together, that drives me so nuts when we talk about specific cases in public rather than overall ideas, it kind of goes back to that saying, wise people talk about ideas, unwise people talk about people. And so when we do specific cases, what we're doing is emotional manipulation, number one. We're attempting to shut down questions or debate around it, because how dare you debate what a 10-year-old victim should have or not have?
Right.
Like, are you a monster? It's intended to shut that down, and it doesn't actually help the 10-year-old. We need to provide the 10-year-old with standards of care, not what emotionally do we feel like we would do in that situation. Quite honestly, my overall philosophy on whether abortion should be legal or not, and people ask me this all the time. Actually, the BBC interviewed me right after the Dobbs was overturned, and one of the questions, they are great at prep questions, by the way. I should give you some. They're so good at it. They were like, did your abortion impact how you feel about this legally? And I was like, I'm so glad you asked me ahead of time, because I hate that question more than any question. You can ask me about my rapes. You can ask me about being molested. That question drives me nuts, because the assumption is, oh, you're only pro-life because you regret your abortion. Right. No, I don't think anybody's emotional reaction should be what we base law on. That's a terrible way to base law. Like, the wind blows this way and that. Like, emotions are not fact. Emotions are our reactions to stimuli in the world around us to teach us about ourselves. And so, no, that's absolutely not a reason why. Mine is based on the biological fact that women are pregnant with human beings, and the biological fact that abortion ends the life of those human beings, induced abortion intentionally ends the life of those human beings. And when do I think that should be permissible? And for me, it's only in the case of the life of a mother, because we have the right of self-defense when our life is threatened. And that's it. Yeah. So it has nothing to do. I will say my experience does impact when I go to legislation advocating for, if abortion is going to be legal, because again, I live in reality, not in Robin's dream world, where all pregnancies are supported and we all get to live with families supported. Like, oh man, my world is great. I wish we all could live there. But in reality, if it's going to be legal, what does informed consent look like? And what does safety look like for women? So, and what does choice actually look like? So that's kind of where I don't talk about should it be legal or not. If it's going to be, this is what we need to do. If it's not, this is what we need to do. I'd like to add too.
Please.
A woman can, or a girl can start releasing eggs without actually having a menstrual cycle.
Yes.
And not even realize that that's happening. So it's possible to have never had a period and get pregnant.
Which is wild.
Yes. So I specifically started targeting my research on the risks for pregnancy of children younger than 15.
Yeah.
Because there's a decent amount of stories about people being pregnant in high school. There's not as much like automatic panic that like that's going to be dangerous.
Yeah.
So I was targeting 15 and younger, which is mostly would be like ages 10 up through 15. And what I found very shockingly to me was that there does not seem to be any statistical difference in the likelihood of there being some sort of maternal mortality situation in women that are pregnant at that age versus women that are pregnant older when they are receiving the same quality of health care. In other words, there was this epic review, and we'll put it in the comments. It was a literature review in the Journal of Family Planning and Reproductive Health Care. And what they were trying to figure out is what is actually causing there to be worse health outcomes for young women, very young women, children that are pregnant. And what they were seeing is that all of the additional factors, mainly the risks that they were seeing as being like always told that these are going to be the things that are higher risk in very young pregnant women, were anemia and hypertension. Those are the two major risks. When they were actually studying why those girls were experiencing those, they realized that it had absolutely nothing to do with their age, and purely due to the fact that they weren't actually getting quality health care, mainly because of their socioeconomic status or because of the social stigma around them being pregnant.
Wow.
So if you had a girl who was 13 and pregnant and you had a woman who was, 25 and pregnant, and they received the same quality of health care, the girl who was 13 had no higher risk of absolutely anything than the girl who was 25. It was all to do with the fact that she wasn't regularly getting doctor's appointments, she wasn't taking prenatal vitamins, she wasn't like having the kinds of testing done that was being done on the 25-year-old just because she wasn't seeing good doctors often enough. And so if they controlled for that, which was the original problem, is a lot of the original studies that were causing some of this panic that this literature review was also going over was seeing that they were not controlling for all of those variables. And when they did that, they were discovering that it was really those extra, that socioeconomic factor and the social stigma that was causing these kinds of issues. So it was a fascinating study. As I said, we'll link to it in the description, or a fascinating literature review, I should say. We'll link to it in the description. It was specifically looking at 11 different studies. And that also led me to the International Journal of Epidemiology, which basically had come up with the exact same conclusion. They were saying that, and I quote, multiple large studies that suggest that young age is not an important determinant of pregnancy outcome or future health of the mother. It is not the age that's the issue. It's the other kinds of health care that they are receiving. And so I think that's really, really important to note here, that there doesn't seem to be as much of an issue with, like, the age. It's not automatically a life of the mother. Just because someone is 11 doesn't mean we have to say it's impossible for them to give birth. This becomes a life of the mother scenario. We need to be providing them with excellent health care, and we need to be getting rid of all these barriers that seem to be preventing most young children that become pregnant from getting that health care. But it's not going to mean an instantaneous, this girl could die. And
presumably, and Robin can agree or disagree with this, but I would think, presumably, while obviously we want her to have the same level of physical health care, she's probably going to need extra emotional, mental care given the situation. Obviously, it's not, this is not an ideal situation at all, but it's shocking. It was shocking to me to get a text from you. So it's physically speaking, it doesn't seem to be what everyone would guess. And so then I'm like, well, I want to know if Robin agrees with that. Does Robin know anything about that? So Robin, jump in. Is this shocking information to you?
Not shocking to me. Not because I have any wonderful medical knowledge. I'm not a doctor, but because I get the pleasure of spending lots of time with doctors in APLOG. And this has come up several times in conversation prior to this whole story.
Naturally. Of course you guys have talked about this before.
Of course. Yeah, of course we've thought through the hard cases, and they've experienced some of those hard cases, and I've experienced the mental health side of some of those hard cases. So with the way that they approach healthcare, shockingly, is Hippocratic oath, do no harm. So they follow the patient, providing the best care possible, and if it arises that there's a complication, they treat the complication with the best standards of care available at that time, which may include termination of pregnancy. And it really isn't age dependent. They don't have a patient come to them, oh, you're, let me tell you, I was advanced maternal age at 35. I could have hit somebody. And
how dare you?
Risk. Yeah, I'm such an obstinate patient. They're like, I might have my last at almost 40, and they're like, after 39, we like to induce at 39. I'm like, nobody's inducing me. My body has done this before. Anyway, so they don't, just because you're a certain age, presume what is that pregnancy going to entail. We don't know. They're great doctors. They follow the patient, and they follow what the patient's body is telling them and what the patient is telling them. So we want exceptions for the life of the mother. However, with that, I go back to, as I alluded to earlier, Josh, your point of we should only do violence when it's the absolute only best option. The way that APLOG looks at that employs the standard of double effect, or the principle of double effect. So we may have to terminate a pregnancy. Does that mean we have to intentionally cause harm to the human inside the mother while we're doing that? And so even in these really difficult cases of young children, from what I have been shared, Dr. Christina Francis and I were on a call with some legislators earlier this week, and they actually asked her that question. And she said a D&C or a D&E procedure has such a high risk of perforating the uterus of a young child. They absolutely would not recommend that. It would be an induction of labor type of situation. And so there may have to be a case where they have to terminate pregnancy, but do they have to cause intentional harm? And so when I was thinking through that, one of the things I thought was, if a 10-year-old's pregnant and has never had a period, absolutely they're going to need not only extra mental health support because they've been through a rape, but also I've had a medication abortion. That's not a fun experience when you've had periods. I was 20, 21.
Right.
And it was terrifying to me. And so I can't imagine a 10-year-old who's never maybe had an experience of that at all, bleeding from that very sensitive part of their body, what that would be like. So
because a lot of girls at that age have a big enough, essentially, the actual world is a diagonal conjugate. Didn't know what that was until last night. But they already have basically big enough space in their pelvis to pass a child through there. You technically want 11 to 12 centimeters in there. And if you have any petite woman, like if you've listened to the podcast for a while, you know I'm very small. I am 5'1". And I still make this requirement, and I am the size of most middle schoolers.
Yeah.
And so there is an automatic thing that's going to happen if you go to an OBGYN, and this is back to these girls needing really quality health care. They need to be regularly seeing a doctor. But an OBGYN who knows what they're doing is automatically, like literally at your very first exam, when they find out that you're pregnant, they're going to measure your diagonal conjugate. How they do that, I have no idea, but apparently they do. And if it is at least 11 centimeters, they're like, we're good. Not worried about you. If it is not, they're going to keep monitoring it and monitoring basically the weight of the baby. And if they figure out that this isn't going to work, it's not going to get through there, it's not big enough, and the child is too big, then they're just going to schedule a C-section right off the bat. So this is basically something that they're very used to dealing with. Because a petite woman like myself has just about an equal likelihood of this being an issue as a 12-year-old. And so it's not something that they're saying is more likely to happen in a teenager. And also we know how to deal with it. It doesn't cause any sort of maternal death. It's not going to be popular to say, yeah, there's probably going to be some teenagers that need to have a C-section. Like that's not a popular thing to say, and I get that. And that's so we're going to have to treat that really carefully in an apologetics type conversation. But it isn't any different than me. Like an 11-year-old receiving quality health care and me receiving quality health care if I was pregnant are going to have the same risks of these kinds of things happening. So that's the